Hello, everyone. Welcome to today's session titled Equity-Focused Social Care in Practice. My name is Nameeta Mota, and I'm so excited to introduce you all to this session with two separate conversations jam-packed with great insights from two communities that applied a racial health equity lens to on-the-ground social care programs. These two mini sessions will have their own discussions, so you're practically getting two sessions in the time of one. So I will try to take up as little of your time as possible, so you can spend more time learning from these great two talks. First up, we will have William Blesser, Amanda Van Vleet, Shemecka McNeil, and Fred Johnson from Duke University discussing their session, Lessons from North Carolina's COVID-19 Support Services Program to Address Social Needs. William Blesser is the Assistant Research Director of Healthcare Transformation for Population Health, Social Needs, and Health Equity at Duke University. Amanda Van Vleet is the Associate Director of Innovation of North Carolina Medicaid at the North Carolina Department of Health and Human Services. Shemecka McNeil is the founder and Executive Director of SLICE 325. And Fred Johnson is the Director of Medicaid Accounts at the Duke Health Population Health Management Office. After that, we will get to hear from Dan LaVallee and Brandy White with UPMC, or the University of Pittsburgh Medical Center, in addressing work as a social determinant of health, one Medicaid's plan approach to partnership. I will also come back and introduce their session later as well. Once again, my name is Nameeta Mota, and I'll be your moderator today. I am a clinical pharmacist at a healthcare startup company called Lumi Health, and I have the pleasure of serving on the advisory board of Siren as an expert by experience. As we listen to today's talk and continue throughout the conference, please keep in mind these agreements for a safe and brave meeting that Caroline reviewed in our last session. And once again, this session will be recorded. The recordings and slides will be available after the meeting. And we'd love for you to ask questions and stay engaged. So please feel free to use the chat window and use emoji reactions during the session. In the interest of time, the Q&A for both of these sessions will be combined and at the end of today's talk. And please send all the questions using the Q&A chat. And if they are for a specific group or a person, please indicate so, and I'll be sure to specify that. So without further ado, I'll turn it to you, Will.
Thank you, and I'm going to share my screen now. And let me go full screen. Swap view. Okay. Everyone can see the slides? Perfect. All right. I'm going to go quickly here because I want to get to some of our discussion. Today, we're going to be talking about a program that North Carolina ran from August 2020 to February 2022 called the COVID-19 Support Services Program. And the simplest way to explain this is anyone who had COVID-19 social isolation in 4 regions of the state shown there in blue, who attested to having struggles with some social needs due to COVID, they were allowed to receive, using a combination of CARES Act funds and some local state funds, a variety of social support services provided through a number of regional coordinators. And this worked in collaboration with the statewide community health worker program. Approximately 43,400 households were served over this time, and the services included things like direct financial relief payments to help with basic living expenses such as rent, mortgage, bills, medical care, and childcare, some non-emergency transportation to doctor's appointments or non-congregate shelters, some home-delivered meals and home-delivered groceries, home-delivered medications, and home-delivered COVID-19 supplies like face masks and hand sanitizer. We're going to talk with some folks who helped to design and run this program. Next slide. Just wanted to summarize quickly. If you want to read more, we did publish a big brief on this, but a team of mine at Duke helped to speak with a bunch of people, 20 some odd folks that were involved in this program in one form or another to understand how it happened in real time. I wanted to highlight some data from one of the 4 grantees through Duke Health, which we have one person on our panel from today. Just wanted to show some interesting data here. They surveyed community health workers working on this program, and a very high proportion of them felt that they strongly agreed with the statement that the work they did through this program made them feel valued by the community. It's just a really interesting thing to capture working in a health-related social needs program. And then when they surveyed folks who receive services, you'll see in the light blue and dark blue, the vast majority of folks, like 80–90%, thought it was really easy to ask for services and to get those services. And we wrote a whole paper on this, so I only want to do this in about 45 seconds, but I wanted to give you a feedback of some of the things we learned from studying this from the program administration side. Human service organizations that were delivering these services on the ground, they really needed upfront capital and capacity building support to be able to do this. They needed liquid cash to be able to build up, for example, making sure they have enough vans to transport people around. Since this evolved rapidly due to COVID, and they were working through a lot of, interesting scenarios coordinating the health and social services sector, there was a very high need to quickly adapt to feedback from human service organizations, from the administrators, and communicate those adjustments. The community health worker program that North Carolina was separately building up was really, really key to identifying these folks that were isolated and connecting them with services. Community leaders were leveraged at the local level to help get the message out and ensure that this could roll out in an equitable fashion. Of course, there was a need for technology to help facilitate this, and North Carolina has been standing up and using a program called NC Care 360, which helps to refer folks between the health services sector and the social services sector and connect them with CBOs. And finally, technical assistance, of course, is really complicated when you're dealing with multiple sectors. So I want to move quickly. I know I blew through that. Let me stop sharing my screen here. Oops. Am I done sharing? Thanks.
You can see it still.
Looks
Perfect.
like you're still seeing your screen.
Okay. Where is the stop share? There we go. So I want to jump into the panel quickly with the time that we have here. I think we have about 10 minutes for discussion before the next panel. And I wanted to start out by asking a question to Shemecka and Amanda. And just a reminder, try to keep your answers to a couple minutes so we can get through a bunch. But, Shemecka, from your perspective as a frontline provider leading a community-based organization to deliver social support services through this program, tell me about a client experience where your work really helped to improve their lives, and what was the most important ability of your work in this program to reduce health inequities?
One of them, one of our clients that I really remember is a client that was in a rural area where nobody goes really. Through this program and through word of mouth from the CBOs, CHWs that were working on the line with the CBOs, they were able to identify that client so we can get to them. This was a great experience. We had a chance to work with other CBOs just in case we couldn't get to those people or whatnot, and kind of see what resources were out there, learning about different organizations and things like that, building relationships with communities that we weren't aware of, which we are still having relationships with now, and now forming new relationships through the SSP program because they heard of our work in the CHWs. So all of this wouldn't have been possible without help from Duke, this SSP program, CBOs, and the CHWs.
Thank you. And Amanda, from your perspective, designing and overseeing this program, can you talk about the application process and the design of the program and how it incorporated concepts of health and racial equity?
Yeah, thanks for the question. So, we knew at the time that we were designing the program that communities of color were being disproportionately impacted by COVID-19. And so we did try to be very proactive about addressing health equity from the start of designing the program and throughout implementing it. So we released a request for proposals to organizations that wanted to apply to be network lead entity type organizations. And we scored them higher if they were a minority or women-led organization, and if they were subcontracting with minority and women-led organizations. We also scored them higher if they were able to demonstrate to us in a meaningful way that they had experience working with populations of color, refugee populations, immigrant populations, and had a meaningful plan to engage with those populations during the program. So we incorporated scoring aspects to proactively choose entities that had experience addressing equity and would continue to address equity. And then on the individual side, when an individual was applying to the program to get these services, we tried to make the application process as simple and easy as possible. So it was a one-page front and back form that just required member attestation. No documentation of any kind was required. We heard at the time that especially undocumented populations were nervous about applying for government programs. And so we didn't even require people to give their names. They could give a different type of identifier for them, anonymous. Didn't require citizenship status, and all of our materials were translated into Spanish. And so, yeah, we obviously collected race and ethnicity and other demographic data. And we were able to see at the end of the program that over 70% of the services went to historically marginalized populations. Yeah, thanks for the question.
Thank you, appreciate that. And I'd like to turn now to Fred, and then Amanda, back to you, but about how other health systems and state Medicaid programs could begin this work. And, you know, Fred, from your perspective of population health management leadership for an academic medical center who oversaw one of these 4 regions for the program, and you're also currently pursuing new work to address social needs, what advice could you offer to other health systems that are interested in understanding health inequities and social inequities and taking steps to address them?
I would first begin with identifying some champions in the health system who understand that addressing equities is a strategy that integrates social and medical care, actually social behavioral health and medical care. And I was fortunate to identify and work with 2 champions. One is our director of clinical quality, who is working on disparity issues and immediately recognized, you know, we have to figure out ways to deal with root causes, and also the integration of social care. The other one was, and this I've seen across other health systems, is our ACO CIN leadership, who immediately, as a first big step, we bought into the whole idea of embedding, as Will pointed out earlier, the resource referral platform that's actually owned by a company called Unite Us in North Carolina. It's called NC Cares 360. So we, the 3 major systems in our region, UNC, Duke, and Wake Med, all use Epic, and they've all embedded in Epic the R&R platform. I think the other thing that was critical with the champions was the issue of intentionality, that we were going to go out and engage community-based organization with the intent of identifying those led by people of color, and begin an organizing campaign to address issues that would help begin the process of figuring out how to integrate social and medical care. Particularly, how do you define the metrics that demonstrate impact?
Appreciate those thoughts, and definitely echoes what we found in the research too, that champions were really critical at every stage of this program. And Amanda, along a similar vein, you know, how can other states and commercial payers begin the process of developing health policy programs to address social needs, especially states that may be earlier in the process of moving care upstream? Maybe they've made little progress statewide on value-based payments, or who may be in a political environment where starting this work may be challenging. Any practical or technical guidance you might have for those states and payers?
Yeah, it's a great question. I mean, I would say just start somewhere. I mean, I don't think that you have to boil the ocean immediately in trying to address these needs, but even starting by starting by collecting data, stratifying by race and ethnicity, but then actually doing something about the gaps that you're seeing and the inequities that you're seeing through policies or programs or value-based payments of some kind to incentivize gap closure and disparities measures. States could start by either developing screening tools for social needs or having plans or providers use any social needs screening tools that they're already using and collecting data on social needs. There are a lot of elements to address social needs that we put in our contracts with our managed care plans outside of the $650 million that we're using for our pilots. And those were things like requiring our plans to do social needs screenings and reporting the data to us, encouraging them to offer services, non-medical social services as in lieu of service or a value-added service. We incentivize our health plans for investing in social needs and equity in the community by allowing any of those contributions to count towards the numerator of their MLR. And if they donate a certain percentage, then they get preference and auto enrollment for members, the next auto enrollment. So I feel like there are ways to start doing the work with existing staff and resources. That said, we also, our Medicaid program partnered closely with our Division of Public Health in North Carolina that did a lot of fundraising and engaged with state and national philanthropies to get some initial funding to support some of our social needs work that then we were also able to use in Medicaid. So partnerships and creating creative funding mechanisms can also help.
Perfect. And I just saw we have a 2 to 3 minute warning. So I'm going to move to maybe the last set of questions here. I'd like to talk a little bit about how the health and social sectors can partner together to reduce health and racial inequities. Of course, noting that they have very different cultures, languages, standard operating procedures. They're very different historically. Shemecka, you lead an exemplar community-based organization with lots of experience working with the health system. What would you want health policy folks and health systems interested in social needs work to know before partnering with organizations like yours in order to work together effectively? You're on mute.
You're still on mute.
Got you. It's kind of piggybacking off of what Amanda said. We use the same kind of metrics, but in a different way, using like communication, like talk to us, talk to the community, listen, write down, speaking to community events, problem solving, like challenges. What can we do to solve the problem? Ask the community. Teamwork. This, like I said, this project wouldn't have been done without the help of Duke, CBOs, and CHWs, and policymakers, grant makers, all of them too. An initiative. The big thing for us that was a great driving force was the initiative to be able to create jobs during a pandemic and also providing sustainable education for our employees, thus creating CHWs. So they can take that with us and then they can move on and, always have some type of background to be in the healthcare. So I would say this, and plus, look at our examples. Duke, Fred orchestrated a great team of people to get this done. And it looks like 80% said, hey, I was able to stay home. Thank you very much. That's what we wanted. People got vaccinated and things like that. Just listen to the community, and who knows best but those community those CBO organizations that are on the ground running.
And Fred, in 30 seconds, I'm giving you the dangerous last word here. Shemecka just talked about some work you've been doing to continue to organize a network of CBOs after this program ended. Could you just talk about, in 30 seconds, your key to success to keep an organization, a network of CBOs together like that?
Yeah, it's the old, I used to be a community organizer. It's the old, it's a combination of money and successes. And frankly, the SSP program, we were able to distribute more than $4 million to CBOs. And so they saw a benefit in collaboration. And we also have won recently some agreements with their transit system around some new ways of dealing with paratransit, which is a huge issue for us. So we're seeing, we had victories in distributing funding to our CBOs, and now we are moving more into the world of policy. And the first issue we picked, we won. So that's always critical in building confidence and solidarity.
Thank you. And I think our time's up, but we'll be back for the Q&A at the end.
Nameeta, you're on mute.
Sorry about that. That was an absolutely great session. Thank you guys so much for that. Next up, we have Dan LaVallee, and we also have Brandy White about addressing work as a social determinant of health, one Medicaid plan's approach to partnership. Dan LaVallee is the Senior Director of Social Impact at the UPMC Center for Social Impact, and Brandy White is the Freedom House 2.0 graduate of UPMC. So without further ado, I'll hand it over to you guys.
Nameeta, thank you very much. And Will and your team, you're wonderful. It's incredible work, North Carolina and everything about Duke, and North Carolina is always close to my heart. So it's always nice to hear from there. So I'm not going to take too much time because the real story here is Brandy. She's one of the most, the bravest people I've met in a long time, and somebody that we value so much here. And I think epitomizes what, we've tried to do at UPMC around workforce development and around social and community-based relationships. And we're just so pumped. So quickly, I'm going to share my screen a little bit, but as I do, just a little bit of background for those of you who don't know. So UPMC is a large integrated system in Pennsylvania. We're based in Pittsburgh, of course, but we are across the state and in a handful of other states. And we've got a health plan too, as well, which is really where I come from and our Center for Social Impact. So we're very excited about all that we can do. We have a large Medicaid business as well as other government programs and across the span. But some of the reasons why that we've invested in social impact and social determinants is because of the membership that we have and the need and our mission and vision to do what we can to support our communities. There, of course, was no greater need and time, than the pandemic. And, for us, of course, as many of you, we were in communities and neighborhoods where hundreds of thousands of people lost their jobs immediately. We already had over 500,000 people on our Medicaid plans, but of course they ballooned quickly, and we knew we needed to do something to step up to serve our community and especially to help people find meaningful life-changing careers that were good wages that would continue to show career path. So for us, we've got almost 100,000 jobs or employees at UPMC, which is crazy every time I say it, but we also have nearly 13,000 openings right now, which is also crazy. So for us, what we've tried to do with that is taking who we are as a company and what we want and need to do within our mission and vision to serve the community with the need that we had. And what better way to help fill the open jobs that we have than to build a program that supports our own Medicaid members and anybody in our communities who has a barrier to work. So look, we've been asked by our community to do this for a long time, and this is what we built and came to. So our program is what we call Pathways to Work. We're of course, we love it, very excited about it. It's been in existence for a couple of years, but it's based on years and years of work in terms of what we can do in the community. So right now, what we have a couple of recruiters who go with me just about everywhere across, especially the Western Pennsylvania region and others, to go out and help people see that they can have a place with us. So many times people just thought we were just nurses and doctors. We are not. We, of course, have many other jobs that Brandy will talk, quite a bit about. So it's about kind of showing up in communities and doing that work, which is great for us. Of course, it's who we are as a company, but it's also a way that we can, continue to build and help our region economically. So through the program, what we try to do again is those community supports. And look, there's no barrier to entry in this program. You can be working on your GED or have a PhD and have fallen on hard times. You can talk to our Pathways team who will be there to help you find a place, who will give you hope, compassion, and really find a place within UPMC. And again, we felt passionate by doing this on the health plan side, but it also makes so much sense on the public workforce side. So we partner with our workforce investment boards across Pennsylvania, and in particular in Western PA, to build new training programs. One that Brandy will talk about here, in a minute, because we're able to show that we can recruit people into these jobs who've had a barrier, who are majority minority, who are youth that have fallen out of school, who've had incarceration, have a disability, have an education gap. So many people were staying at home and caring for their loved ones during the pandemic and left the workforce. We want to be here to make those changes. And so that's kind of how we built a program like Freedom House. There's some stats on here. Certainly, can talk through any question or with anybody else individually. But what we love here is building these new training programs with public dollars plus ours, to really make a difference, in our community. So kind of without further ado, I'd like Brandy, if you could, as you and I've talked so many times, share a little bit about your story and, how you came into Freedom House, which, as she'll tell you, is kind of an entry-level medical EMT role program that, I'll give you this for a minute. That was kind of it was based in the 1960s here in Pennsylvania. It was the start of EMS service across this country. And it was a training program for people who've been out of work. And, for us, we wanted to bring that program back after it had kind of taken a lapse and, moved into different places. And we restarted that program. And that's the program that Brandy had joined. So enough of me. Brandy, why don't you share a little bit about your story? You're not going to have a little chat for the next 8 or so minutes. All right. So why don't you give a little bit?
Okay. I can honestly say a little over a year ago, I was released from prison, and I can say that I was feeling hopeless. I thought that I would never be able to make it into the medical field. Again, I used to work in the medical field my whole life. I made a mistake and things happened, and I ended up going to prison. And I was in prison for a little over 6 years. And even in prison, I was thinking there's no hope. When I get out, there's no programs for us. I didn't know where my life would be. I knew I wanted to better myself. But whenever I was released, I was in the halfway house and I came across a brochure for the Freedom House. And I ended up calling it and getting an interview, and I got accepted. I was in there, but I was still having my doubt because the program just seemed too good to be true. It just, I didn't believe it. So I was questioning not the program, but like myself. And I was asking the coordinators, like, are you sure? Do you know, like, I was in prison? And they reassured me that they know and that they can help me in some position. The Freedom House is for EMT, but they also let me know that if I'm not able to do EMT, that they will still fit me in within a job within UPMC. We were guaranteed an interview at the end of the program. So I did. I gave it a chance, and it's an amazing program. Even throughout the whole program, they helped me with any barriers, transportation. I didn't need it. I didn't personally need it, but they help with like childcare. And there's so many more things that if you have any kind of barriers, you need your credentials. Like, they're there to help you get back into society and work good job. So I completed that program, and then I was told that I wasn't able to do the EMT while I was still on probation. So they referred me to the Pathways to Work through UPMC and said, they gave me different options, maybe PCT and different opportunities. I went with PCT because I was a CNA for many years. So I had experience in that department. So I went with PCT, and I've been working there since April. And it's like my life has changed around within the whole year. Like, I feel more confident. I feel like I'm a human being, like I have a purpose in life. And I would recommend this program to anybody going through anything, because it has helped me get to where I am today. And I'm not even done. There's so many more opportunities within UPMC that I can branch off to and help better myself. I'm in a happy place right now, and I owe it all to that program, Dan, UPMC, for everything. That even giving me a second chance in this opportunity is a blessing in disguise. I would have never even imagined I would be where I am today.
Brandy, you are exceptional. And for everybody out there, she's just coming off a night shift too, and like, so unbelievable. I don't have to do that. She's incredible. So, I mean, I think, we want, she's so brave in sharing her story. And, I can't tell you how many people have come up to us who've heard her story. She was just on a national NPR story again, and it's unbelievable to be able to replicate this here in Pennsylvania and then across the country, that we can do kind of, compassionate workforce development and be there and listen. We all have loss in our lives in some way, shape, or form, and it's all about coming together in that way. So I guess, Brandy, in the few minutes that we've got back, after the almost 6 months that you've been, where are you heading? What do you want to do? Obviously we love that you're where you're at, but tell us a little bit about where you want to go, and and a message to anybody else who might be listening to you today who's in a similar spot.
I mean, I would love to do nursing, RN. I don't see, I still have my doubts, but I think that it's still possible. But I definitely want to gravitate up in the medical field and just better myself and continue to educate and just grow within UPMC.
I love it. That's always music to our ears. Let me tell you, because as many of you who are working at hospitals, nursing shortages are real, and we really feel like this program, and of course, so many of our colleagues do wonderful work and continue to build. If we all can be together and helping to show a path to further education. I know for us, through our program, what we've always done is help support tuition for nursing and other degrees, and we'll continue to do that. And it's just about opening a door. And I guess in the final, before Nameeta, back to you, I think where anybody out there who's doing similar things like this, I can tell you, I did not know what I was doing around some of these workforce development programs a couple of years ago. So please come and ask. This is what we can all do together in our sectors, whether it's healthcare, workforce, whatever it is, together to build lasting models. I believe that this is one that can go across the country. We're trying to take it across the state first, of course, but we're here. So please, know that it's an open door here. And I know Brandy shares her story everywhere too. So please reach out to us. It's we feel very incredibly passionate about this work and what can be done. And I guess I'll leave you on this too. What we've seen too is that the individuals that are working with our pathways team, so Brandy and others, are staying longer and at better rates than people who aren't. So we're seeing that, like, just a more just hope and trust in somebody being there results in better retention, and of course different recruitment. So we love it and we appreciate it. So Nameeta, back to you. I think we're right on the time, or hopefully. So
you are. Thank you so much. And Brandy, it was so heartwarming to hear your story. It's so important to give people hope, and in which your experiences now, especially if you go in healthcare, empathy is a huge part of that. So you already know some of the barriers that people can experience, and everyone is all the better for it. And both of these initiatives were so well thought out, and we can all take so many ideas back to our daily lives. What can we do to help people through our work? And I'm really excited to hear any thoughts and questions from the audience. I know we have until the top of the hour, so we can get into our Q&A session. I want to make sure we have time to get people's questions in. Once again, if you could send any questions you have in the chat, or you can, yes, raise your hand like Caroline mentioned. And if your question is for a specific person or group, please say so. And I'll try my best to get all the questions asked in the time we have left. And I do have one question here for Dan. What would your guidance be for health systems or health plans to build new workforce development programs? Where do we start in all this?
Yeah, sure. So that's a great question. So the first conversation I ever had was with our Workforce Investment Board, which as some of you will know, they exist in every single county across America. They're, formed from federal legislation, and their whole goal is to connect employers like our large one, training providers and job seekers and others to enter into partnerships, training programs, and referral pipelines. We went there, they changed the game. We would not have Freedom House without them. They're called Partner for Work in our area, of course, named differently elsewhere. So that's one. That is one big one as a place to start. Because there's just unlimited organizations, and there's so much external funding as well for apprenticeships and training programs, that as you make the sell to your leadership, as I've certainly had to, we wanted to make sure we were blending our dollars that we were supporting with this with other public workforce, funds as well. So to all you health system people out there, that is the number one, I would say. And then also having this kind of community-led workforce recruitment team has been tremendously helpful in just showing up everywhere and ensuring that we have the best pipelines with community groups that also provide other job supports. Brandy was linked with an organization that does wonderful work and had another kind of job coach supports with her. We love that. So those are two things.
Absolutely. And I have a question for you, Will, as well. Improving health equity requires different skills, policy designs, and accountability standards than the traditional health sector focus on population health management. What practical steps can health systems take to encourage more accountable health equity and also build provider skills to improve equity?
Yeah, that's a great question. And there's a lot of things that could be done there. I will point to a few. I think taking steps towards simply having a more community-oriented governance structure that oversees the program that you're running would be a great first step. So there are some states that do this already. Oregon has their coordinated care organization model, which is a way where they get essentially paid prospectively to be accountable for care, but they also have significant community membership requirements on the boards of those organizations. The federal government is taking steps in this direction too with some of their new models like ACO REACH, which is going to have some community governance requirements. But of course, there's more things than that. You can provide upfront resources specifically to help build partnerships with the social service sector. We saw some of that with the North Carolina program. You can do things to support better data collection around social needs so that, as Amanda mentioned, stratifying your existing data by socio-demographic categories is a great first step, but also we want to get better data moving forward. You can, of course, the federal government's trying this too with that ACO REACH program. You can ask your the folks that are in your health programs to create a health disparities assessment plan and a plan to work together with community organizations to address that. There's a number of tools that exist out there, and we haven't even gotten into the actual payment structures yet, but just wanted to throw that out there, and I welcome any of the other folks' reactions on the call as well.
That was a great response, and that you definitely think through all the pieces in play, which is such a huge part of the problem too. And I see another question for Dan, even though I do see a response in the chat, but it looks like we have a question from Gillian. So what types of outcomes are being used to measure success of the workforce programs? I know, Dan, you're responding in the chat, but if you want to elaborate over the talk as well.
Yeah, and I think actually a couple of my colleagues who help with some of this data tracking and who lead our evaluation center are at this meeting. So they're wonderful and they do so much of this work. We track hires, of course. We have overall hires off of our own Medicaid program, which is something we can see. So of course, getting people in the door, but then are they staying? So we're starting to track, as I was alluding to a little bit, are people staying with us after 6 months, a year, which is the big factor. We know that there's quite a bit of an expense for our HR and training side if people don't stay for a year. So that's got to be our whole goal to prove the efficacy of overall pathways to work is going to be, around that. And then of course we're tracking who are we helping to find roles? What's their education level? Those are some of the big ones. And we also do try to track as well how much external funding are we leveraging for this? Because that's got to be the name of the game to build sustainable, replicable models across the state and the country. Are we effectively, bringing our own dollars to help match and leverage other workforce funds, which of course are everywhere now with the Rescue Plan, with the Workforce Innovation Opportunity Act and other avenues. So we feel like that's kind of a strong way to show it. So a little bit there.
Thanks for that. And I see a question for Brandy. What advice do you have for organizations that want to set up similar workforce programs?
Advertisement is a big thing because even in the halfway house, like the Freedom House brochure wasn't posted there, but the halfway house from what I was told, denies some people that ask, can they put their brochure in there to for us to see and be able to know who to reach out to. They don't allow just anybody to put brochure. So I would just basically more advertisement just to get it out to the community, because there's so many people that don't know about certain programs. And the more we know, the better that we can progress. And that's what knowledge is power, just knowing something and taking that initiative. Because if I never seen a brochure, or I wouldn't even have known about Freedom House. So it was advertisement. And even going to some of the communities and just speaking and just getting yourself known to the public. And I can't even express how happy I am, because even being in with UPMC, they've made me feel like family. They're never judged me, nothing. Like, I truly feel like one of theirs, and I feel like I could stay a lifetime. This is a career of mine.
Make us feel that way.
So
Thank you, Brandy.
That is amazing. And yes, getting the word out is so important, but also making people feel like they have a home there is also so important, to make them feel valued. And it just causes a whole cycle of bringing everything to the table. And I do have another question for Will. Cross-sectoral collaboration is key to addressing unmet social needs and improving health equity. That being said, the health sector and human services sectors have a lot of differences in the terminology that they use, their organizational culture, the funding sources, the power dynamics, and standard operating procedures, which can all complicate the collaboration. How can we foster sustainable collaboration between them? And what are some, I guess, takeaways that you have? And
actually, I think we have some other people on this call that would be better to answer this than me. But so I'm looking at Fred and Amanda in particular, who were involved in answering this question, I think, from a decentralized approach, right? The pilots, North Carolina's Medicaid waiver, which is kind of like an extension of that COVID program on a much, much larger scale. They decided that they wanted to allow for regional variation in building these networks of community-based organizations in order to have one organization who is embedded in that area of the state that knows a lot of these organizations and knows who would be good at doing what. So I don't know if Amanda and Fred would have anything else to add about building those relationships cross-sectorally, at the regional level.
I'll jump in. We have a 20-year relationship with we are in 7 counties with most of our health departments and our Department of Social Services. That over the 20-year period, we have worked on multiple strategies and interventions. And so the trust level has grown to a point where the speed of our interventions has dramatically changed in our ability to enact change, whether it's at the policy level or the programmatic level. And yes, language is correct. They have different cultures, different language. Even the definition of poverty is different in our school systems, in our health departments, in our DSS, and in our workforce development programs. We like to begin right there and trying to get uniformity just on that. But it is a matter of establishing trust, and it is a matter of taking the time to build those relationships, identifying winnable strategies, and that enables us to work together when we get an issue that's quite a challenge, and moving people from a mutual self-interest model to an enlightened self-interest model. And it's one of our overarching strategies. How do you take a leader who has say they only have a win-lose perspective and move them to a win-win perspective with the understanding that when the community improves, or neighborhood improves, everyone improves in terms of their quality of life.
And I might just, sorry, Amanda, I saw you.
It's okay, go ahead, Will.
I was just going to add that I know there's a lot that can be done in the RFP process. So, like the process, if you're designing a program to solicit the organizations to apply, I think that is an underrated tool for identifying organizations that would be well suited to work cross-sectorally, or in the COVID program's case, that is staffed by historically marginalized populations and women-owned businesses. I think like that's an underrated tool that a lot of policymakers may overlook. Is just simply putting some scoring criteria and track record requirements in there. But Amanda, I see you are off mute as well.
Yeah, I was going to add two things. One, I think that we have found that the role of our network lead entities has been really vital in bridging that gap, at least between our health plans and community-based organizations. Our network leads, they network of community-based organizations and then connect those community-based organizations to health plans. And they really serve that translator role between the two, and also make it a little bit easier for our health plans to interact with, like 3 main entities rather than 150 direct CBOs. But they're really good at facilitating interactions between the CBOs and the health plans, advocating for the CBOs to the health plans, et cetera. And then the department has also played a large role in, at least initially, setting up infrastructure and like the ground rules, mostly to make sure that we don't over medicalize the CBOs and we make it so they're not used to Medicaid program integrity requirements or built claims system billing. So we set up what we aimed to be a more HSO or CBO friendly system, and then basically give our health plans and our network leads very specific roles and responsibilities so that we are shifting those responsibilities to our health plans and network leads so that they take them on over time to be more sustainable.
Whew, that was such a whirlwind of 2 amazing initiatives. I wish we had more time, but we're right at the top of the hour. I want to thank both groups and the audience for having such an engaging discussion. And once again, these 2 initiatives were so well thought out, but they also did a great job of showing how complex it could be. So it's really important to think of those and also think of the people who these programs are meant to help. So you guys both did a great job of that.